Thank you all so much for joining tonight's webinar. We see from the overwhelming response, number of registrants, and the so many questions that came in that this is such an important topic. This topic comes up frequently, and it's often one that many women are not comfortable discussing. Sexual health, however, is important to one's overall sense of self and well-being. And many women do notice a change in sexual function as they age and go through menopause and beyond. So tonight I am honored and thrilled to be here with my esteemed colleague, an expert in the field of sexual medicine, Dr. Sharon Parish, to delve into this sensitive topic. Dr. Parish is a professor of medicine in clinical psychiatry and a professor of clinical medicine at Weill Cornell Medical College. She's the director of the medical services at New York Presbyterian Hospital, Westchester Behavioral Health Center. Dr. Parish is an internal medicine physician who specializes in sexual medicine and menopause in her consultation practice at Weill Cornell Medicine. She treats a wide range of conditions with an individualized and integrative approach that incorporates both a medical evaluation and biopsychosocial assessment with an integrated plan of care. She is President Emeritus and Fellow of the International Society for the Study of Women's Sexual Health, also known as ISWISH, and Menopause Society Certified Practitioner. So, thank you so much, Dr. Parish, for being here. And let's get started. Let's just define the different aspects of sexual function.
Well, first of all, thank you for this wonderful honor and pleasure. And I'm so thrilled that we have the opportunity to talk to so many women and men, I don't know who's on,
Right.
about this important topic and that we can open up this conversation. And thank you for that very mouthful introduction. But to make it clear, because people are confused, I am an internal medicine physician and I am interested in women's health. And also I do some work in the area of behavioral health and psychiatry as an internist. So that's where sexual health comes in, because it's kind of like truly speaking of what is the components of sexual health. And I think one of the most important messages I like to give is it's like a field I really enjoy working in, because it really is the integration of the biology of sort of like the border between normal and like what is just adaptation to age when we talk about menopause and there and beyond, and what's sort of normal changes and how do we adapt. And then just the social and the context, the relational context, the cultural expectations, the dyad if you're in a partnership. And these are all this coming together makes this a really wonderful and gratifying way to work with people. And the other point I think is important to make is that sexuality is not like only, watching an encounter on in a movie, a rom-com. It's so much more than that, right? There's a lot of domains of sexuality, and that's something I try to open up with my patients.
Sure. And I think when we prepared for this, we talked about that what's right for someone else is not necessarily right for you, and everybody has their own experiences.
I mean, that's absolute. I mean, there's some like ideas about like sort of what are the domains of sexual function that are like objective categories. And there's things that people notice that have changed for them, and navigating whether that's an adaptation answer or if it's a problem that for which we have treatments and we have remedies and we have interventions that we can offer people that will improve things is part of the work of the field of sexual health and sexual medicine in clinical care. And it crosses both of our disciplines in medicine, in gynecology, and in other fields. The typical idea, you asked me like what is, the domains of sexual function, is that it's based on some like the famous, veterans of sexual research. So there's the Kinsey reports from the 50s and the Masters and Johnson work. If you ever watch Masters of Sex, it was my first, binge watching, watch at home on TV and stuff. But so the idea is that sexual response kind of progresses from desire, and that could be like in the moment wanting or anticipating, and it might be paired with fantasy or wanting. And usually it could be with oneself or feeling turned on internally or in the context of a partner and liking and wanting. And then there's feeling turned on or which leads kind of from wanting to intra-event wanting, which is arousal, being cognitively or mentally turned on or aroused. And then there's our genitals. Do our genitals get turned on? Do they respond to stimulation? What are the patterns that make people know they feel physically or genitally turned on? What about the rest of the body? What is arousal? And then there's the climax or the orgasm. And we can certainly talk about whether that is a part of normal.
Mhm.
But many women, have experienced it and feel distressed when there's a change or it's gone. And then in the male model, there's this idea of refractoriness or in between. And a more positive way to look at it is satiety, and attention is directed at other things. That's how I like to think about it for women. And whether those periods of attention to other things change as we get older is another question, right? Rather than calling it like refractory or loss of interest. Where does that boundary come? And so those are the ideas about sexuality. And the other thing is, and you and I've, talked about this, which is that maybe it's not so linear for women and maybe for anyone, you know. Maybe the patterns reverse sometimes. We're not thinking much, but a partner presents a viable stimulus and you say, hey, that's not such a bad idea. And then women get turned on first and they're like, oh, I guess I want to do this. And sometimes that's the way it goes, you know.
So we'll delve into all of this in a little bit more detail. And then the other thing that comes into play with our menopausal patients, especially and as women age, is that pain can play a factor into all of this. And I hope we'll spend some time talking about that as we go on.
Oh, absolutely. Right.
Yeah. But let's start with just the desire, right? So libido, desire. I can't tell you how many times a day women come in and noticing a change or being sort of distressed by the fact that they're noticing that they don't have the same sexual desire that they used to have. So what are the different parts of our libido, our desire? And then, we'll talk about it in a little bit more detail.
Yeah, sure. So I alluded to this a little bit. I think there's like the traditional idea of thinking about wanting sex, feeling horny, feeling turned on, having like things that are named fantasies. And that has a concept of a drive, like your motive, and it could be paired with motivation. Like,
Mhm.
I am feeling this way, I'm thinking about this, therefore I'm motivated to have a sexual encounter of some type. It could be with oneself, it could be with a partner. It could be like visually seeing something that someone is drawn to, watching a movie, reading erotica.
Mhm.
And then sometimes those stimuli or those things cause us to, you're like want to want, so you seek them out, right? To feel more turned on. And I think that's what people traditionally call like just endogenous desire, spontaneous desire. Desire can be linked with motivation, although desire is not the only motivation for why people agree to have sex. Sometimes it's for other reasons, like to feel close, to want to be with a partner, to please a partner. And we hope those motivations are always positive. And
Mhm.
there's some interesting books and things for people about the reasons women have sex. But I think for another day about the negative reasons women agree to sex, and we hope that they're mostly positive, right? And then there's this idea, which we were kind of also alluding to, of what's called responsive desire. So you might be neutral. Maybe you're like working on your next project or something else is going on and a partner presents the idea or something comes up in something you're watching or doing where you then the stimulus causes you to be able to be responsive. And most typically in a like the sort of women's cycle or what's called the incentive response cycle, an incentive stimulates or motivates us to be like, I wasn't thinking about it, but or someone just gives, a physical stimulation. You get aroused and then you can respond and say, hey, I want to be involved in this. That's responsive desire. And both of those patterns can be normal. It's when neither of those are normal that I typically see people come to me, right? They can't, they don't feel any spontaneous desire. They can't generate fantasy. Confident stimulus or a partner suggests sex and they find themselves avoiding. They can't, or even if they agree, they don't get into it. And that's where I think it becomes clear that there's a distressing problem for someone.
And those are conversations I try to have with patients in the office too. So when women are distressed about not feeling it the way they used to, we know, and we talk about this a lot on these webinars, midlife women have a lot going on. We have,
Yeah. Yeah.
young or young adult children, we have maybe aging parents, we have the peak of our careers, we have whatever other stresses in our life. And so for some women, they're not thinking about wanting to engage. But then the question is, like you're saying, can you engage can you respond and engage if maybe if someone else initiates, right? And I think that's the differential, right?
And sometimes being working on arousability is the focus. So like even if you're not thinking about things, can you like clear the decks in your mind or in your life to be responsive or receptive, even if it's not on your mind, like when the opportunity presents itself? And I think, there's a lot of it is dialogue, but just simply explaining to women the difference can often help people get in touch with that. And typically responsive to women don't have like when they're in new relationships or shorter relationships or I think I see a difference between younger and older women, but certainly in long-term relationships, those patterns can vary from time to time.
So I
Right.
don't know if you ever listened to Mel Robbins, but I was listening to her last week and she talked about this a little bit that, when you're in a long-term relationship, maybe you just have to schedule time. And then she said, in reality, you've always scheduled time because when you were just dating, well, what do you think you were doing? You were scheduling time. And so now just in your long-term relationship, maybe you just have to set aside time. I don't know how you feel about that.
Yeah, no, people got that. It was sort of more naturally understood that that was how women got themselves ready. They were, or even, younger women getting ready to go out with their friends. There's a whole ritual. People leave work. I don't know, they go to the gym, they take a shower, they get changed in their going out clothes. That's all preparation,
Right.
right? And when you get older and you're like doing your life, you're not preparing. So you're not in the mind, body, physical space or mindset. And that's sort of something that you can kind of remind people like, oh yeah, I did used to do that. I'm not doing it now. It's not surprising. I'm not feeling into this.
Mhm.
But where I find that people want to get clinical help is again, just to reemphasize this, where none of those things work. And that's when we start to look like, are the biological forces or factors in our body that govern the ability to get their mind turned on or have their body get aroused or their genitals feel stimulation? If that's not working, then people become upset and frustrated and distressed. And that's where we start to look to say, what are the factors that are interfering with that working? Is it change in their body? We can get into that a little further. Is there a psychological barrier? Is there a relationship factor where that person is no longer having that impact because we have a certain feeling or dynamic?
And so a lot of questions came in about this, like how do our
Mm.
hormones impact that? And we can talk about that in a minute, but there are a lot of other things too. Medical issues, medical problems, medications. I think you said relationship problems. All of that is going to impact in maybe having trouble with this.
Yeah, so we're talking specifically about endogenous or spontaneous libido. Inside is endogenous or the ability to be responsive. The biological factors that like kind of big categories, if women are thinking, well, should I think about this, is we can get into the role of hormonal changes of in the perimenopausal and after their afterlife. Things like, so the categories of medications, sometimes vascular drugs, blood pressure meds, um, thyroid changes and its treatment, um, problems with like after breastfeeding, some other hormones other than menopausal hormones like prolactin. Those are kind of the biggest categories that I see. Antidepressant
And that's a big
medications.
one.
Yeah, I'm
Antidepressants are
sorry,
big.
I meant to mention that when I
Yeah.
said hypertensive. I skipped that because I was jumping to the medical. Those are some of the biggest factors. There aren't that many medical factors. When we talk about arousal in the genitals, it's a little different because then there's the role of the genital changes, pain, role of estrogen. But I find that it's pretty easy to identify those things, right? If someone looks and asks, because there aren't that many, even though there's long lists in textbooks, right? Yeah.
Yeah, so before we really go into hormones and the changes in the body that happen, Do you want to just talk a little bit about like arousal and orgasm and, and what's sort of changes happen there or not for some?
Sure, sure.
Yeah, yeah.
So, I think it's good to have like a lot. What we find, like when I was involved in some survey work around what women understood about their different types of sexual response, and I think sometimes women don't always can't perceive the difference between where the problem is, and sometimes it's helpful to think it through and get people to kind of break it down because then you can solve it better. So the bridge between wanting, engaging, and feeling turned on is what we sometimes call mental or cognitive thinking arousal. So, like, is it that you can't, once you're there, you can't stay present? And that's what I get people to tune into that. Are you thinking about a million things, your shopping list, your work for the next day, some emotion about the partner? And if that's the case, there's certain types of approaches we take, right? Sometimes it's counseling, CBT, cognitive behavioral therapy can
Mhm.
help with that. Mindfulness or mindfulness focused activities. Everyone's hearing all about mindfulness, getting the mind to calm down and center and be present to the experience. Then there's a different kind of arousal, which is we mentioned it already, is the genitals being able to turn on. And some of it is technique, right? And having a confident technique or stimulus. And one of the biggest messages for this audience is that the sensitivity of the genitals changes with age, right? We get a little drier, the nerve endings become a little bit less hyper responsive, they respond less well. So sometimes women need more stimulation with age, and it's a matter of making that adaptation. It could mean more direct stimulation, like we were talking a little bit more about treatment, but the genitals might not be, nothing may be wrong. It just is sort of natural. As women get older, they need a little more stimulation. Sometimes it's manual, oral, a vibrator. So the factors that influence your genitals being able to respond are the nerve endings and the lubrication, which is somewhat dependent on hormones and the tissue. Your changes with estrogen with aging, and that's related to menopause, and blood flow. And there are little small vessels in the blood, the in the body that feed that area. So if we think someone's having a change in their genital arousal, it isn't just something that's related to the aging process where you need to just amp up the stimulation. We look at the mucosa, the lining, lubrication, the blood flow, how the nerves are responding. And sometimes we can see a way to offer a treatment there. And then arousal, it can lead to climax, or what people call climax, orgasm. And that's also a vascular event, but primarily a neurologic event that's strongly influenced by the mind. So there's often the role of looking at feeling comfortable, feeling safe, inhibition, and an experience that, the way that one interacts with a partner. And then there's neurologic processes, our sympathetic nervous system and our sensory motor system. These are small nerves in that area that are responsible for that type of response. And so that's sometimes a medical factor. I don't know, we're kind of talking a little bit what can be wrong, but also
Yeah,
what
but also being present, I mean,
yeah.
that's part of being able to reach orgasm too, right? So your mind is not wandering a million places, you're present in the moment, right? Is that
Right. Well, and that can be a continuum from being able to get turned on and feeling mentally turned on to getting your genitals to feel turned on
yeah,
and being able to climax. And women sometimes will say to me, like, I get there, but I can't quite, I feel turned on, but I can't quite get there in my genitals. And so sometimes there's changes in orgasm thresholds, in intensity,
yeah,
the arousability to reaching orgasm as women experience the menopausal transition and beyond.
yeah,
Changes in sexual function, I do want to say one more thing, are not a menopausal event, right? They overlap and correspond with changes that happen throughout that 10 to 15 year transitional time, right? So some of it is more hormonal than others, right? Like the mucous membranes and lubrication and dryness and discomfort, which what I guess this is an important message, we might as well get it right out there. If someone is feeling dry in their vulvovaginal tissues and they're not lubricated or even in pain, arousal and orgasm may not occur because they're uncomfortable. So that's the first thing we do is check for that
So
and find
pain
out about
totally can impact our
that.
whole sexual function, right? You talked about the physiologic changes that happen, right? We put that into the genitourinary syndrome of menopause. We try to call it that. But we know that estrogen, which we have until we get to menopause, really does help the tissue, the vaginal tissue, right? And when we lose our estrogen and we go longer without it, it's fairly universal that most women will really experience changes in their vaginal tissue, which you said, I'll just repeat, the dryness, the thinness, the change in the vascularity, and can really impact, just their comfort level and also their sexual function. So, we're going to talk about that in a minute, like what we can do. Why don't we go to that right now? What can we do when women have pain with intercourse or just with any kind of sexual activity?
So what I remember, one thing we've chatted about is just for some women, feeling the lubrication and feeling wetness is the thing that turns their genitals on and actually gives them, we should talk, when we talk about responsive desire, we should make sure we make this point. It gives them that turned on feeling that feeds back to their brain and causes the responsive desire. Like, oh, I'm feeling wet. Oh, I'm kind of getting the idea of sex. Oh, maybe I'll find my partner, or maybe I'll find my vibrator, or maybe I'll find myself, And
I talk about that a lot. I call it feeling juicy, right?
right, feeling juicy, feeling the lubrication. And so one of the things I do a lot of my practice is ask people, like, what makes you feel mentally and genitally turned on? Is it the anticipation? Is it fantasy? Is it feeling aroused first? And then trying to enhance that response. And you don't want to change people and say, no, 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 you have to read a book and feel fantasy first. And if that's not how it works for them. And whatever people are distressed about is what worked for them isn't working. So the first thing to find out is why is it different? And then sometimes it's adapting or understanding how they're different now and what can we do. And sometimes it is trying a new way, right? And seeing how that goes. I do sometimes find the reverse, and I think that we're pathologizing this a lot, making it a problem. There's a liberty that sometimes you see that is different than problem, right? In women who are midlife, women whose kids leave, women who feel a
Mhm.
sense of empowerment in their career, and they're not sure how to navigate feeling a renewed sense of ownership or empowerment to say, why did I just like lay on my back and receive sex instead of telling someone what I wanted for the last 30 years? I've heard that. Tell me what I need to know, how do I, and then we send people to information, right? We'll teach them about lubricants, how to get moisture on their own, have them use a moisturizer or a lubricant and say, hey, this isn't comfortable. And, what used to work, I now need, and learning how to ask for it because they're feeling more empowered. So, teaching people about vibrators. There's a website that I often direct people to who even maybe have been sexually active for years called I think we talked about this, OMGYES. It's a verified medically, sort of acceptable website. That is an set of educational videos around teaching women to learn manual stimulation patterns for their vulva, vagina, and clitoris to learn to be more generally turned on and be orgasmic. So like sometimes people never had to do that because they were so arousable, but they need more stimulation and now they want to learn,
So
as
you're
an
saying educate yourself and then
right,
also educate your partner if that's relevant, right?
right, right,
Yeah,
exactly.
yeah,
One thing I realized we didn't talk about, and I know there's always people are very, especially with we live in New York, so all the New York Times press around testosterone.
yeah. We'll get to that. I want to let's do
Yeah,
that. So we talked a little bit.
let's talk about that when we can. Yeah.
Yeah, we definitely are going to get to that because there are lots of questions about it. So let's make sure we have time. We talked about moisturizers. Moisturizers are kind of like a maintenance. I describe it to my patients as like putting it on your face. You kind of have to maintain the vaginal tissue. So it's not like you use it just when you want to be active. You use it all the time. Lubricants. are kind of like to oil the machine. When you want to be active, you use a lubricant,
100%.
right? Sometimes
Yeah.
we need dilators too to help like really stretch the tissue because the tissue, as we go through menopause and beyond, the vaginal tissue can lose its elasticity. So sometimes vaginal dilators can be a very effective way. But when someone asked on this, like if you haven't had sex in 20 years, can you still do it? Sure, but you definitely can, but you might need some help to kind of help expand the tissue and help moisturize it.
It's kind of like you don't just go to the gym and run 5 miles on the treadmill. You start out slow. So you prepare, you get your sneakers.
Mhm.
You start by lubing up things, stretching, stretching things out, and then, gradually getting used to the idea of moving things.
Right. And then vaginal estrogen. So, vaginal estrogen, maybe you heard in November, all hormone therapy lost the black box warning. We were really expecting it to come off of the vaginal formulations because really almost everybody can use vaginal estrogen. If you've had breast cancer yourself, we'll talk to your oncologist. But in general, almost everybody can use it, and that does improve a lot of the things that we just talked about: the moisture, the quality of the tissue, the blood vessels there. So, then there was a question here, how safe is it if your mother had breast cancer? Like I said, almost everybody can use vaginal estrogen. Sometimes, again, we have to consult your other providers, but that is really good. And it's the kind of thing you have to keep using, but it is a way to really help with the tissue quality and therefore the pain. Um,
I mean, I think just to like make sure this is super clear, we start with if someone, we think about this if someone is saying, yes, I'm uncomfortable, and that's why I'm no longer thinking about it. I might even be avoiding it. I'm not responsive. My genitals don't get turned on at an orgasm because I'm uncomfortable, or I'm worried that I'm going to be uncomfortable. So there is kind of an approach. You start with a moisturizer, use a lubricant. If that, it used to be, we'd say to people, if that doesn't work, we'll add hormones. But I think we're jumping the hormones up more and more and more and saying, hey, it's so safe. Nothing, everything should have a benefit risk conversation, contextualize it for an individual. But it's very different than giving hormones throughout your body, which is now been liberalized too, and is a whole nother discussion about how to
That's a whole
understand
nother
that.
conversation, but
Yeah.
that's the point. Like it's a local treatment, it's not a systemic treatment. It can be used by so many people, and it comes in different formulations. There are creams, there are suppositories, there are rings, so we can find what's right for you also.
There's
So,
also another product which I find some women really do well on, which is a combination of sort of estrogen and androgen pre hormones. It's called Intrarosa.
mhm.
That's another option yet, and you would have a conversation with the person writing your prescription as to what's best.
Right,
But
that one is the one that's specifically marketed for painful
yeah,
sexual encounters, right? So,
so some people like the addition of a little androgen because the tissue is sensitive to androgens. So, does any of this make us like get into our system and make us feel more turned on? The feeling is probably not, but if things are not so cut and dry, like if you're feeling moisture, as we were saying, and you're feeling less pain, and you're feeling like, oh, this is going to be a positive experience, and empowered that you've done something to feel better, that feeds
mhm.
back to the brain and it has a positive enhancing effect.
So we briefly talked about systemic hormone therapy, and a lot of questions came in about that, but we're not going to really delve too much. We've done that before, and we'll do it again. Um, but what do you think about that in improving sexual function and sexual desire?
So I think like to focus on that particular question, that we love hormones and we have to talk about that some other day, like in more depth. But we like them and we like to talk about them, I should say. And they're not for everyone, systemic hormones.
And they
But
might make you feel better, and in feeling better, it might improve your libido, but I don't think they directly
so
improve.
what did they do? Right. So there is some debate among experts in the research about whether there's any direct effect of estrogen on the receptors in the brain that trigger neurotransmitters and hit the brain centers that are responsible for what's called pathways of desire and arousal and responsiveness, which leads to orgasm. And some argue that, in fact, that there may be some, but the evidence is kind of points to the idea that it's indirect,
Mhm.
that if you're feeling better overall, you're not as tired, you're not waking up with hot flashes or having intrusive daytime hot flashes, and the menopausal symptoms are calmer, it will make your libido better. Rested women not feeling better do well. That said, some women do say it seems to impact their well-being and that overall well-being or impact and the role of hormones on perimenopausal women in mood is another thing. But the
Right.
answer is that it's not a direct treatment for low libido per se.
And with that, we're talking specifically estrogen and progesterone.
Good.
So let's get to the other one that everybody
Yeah.
wants to talk about, and that's
That's
testosterone. Why don't we give it more? How do we give it, and what can it do for us?
Oh, the wonder hormone of the New York Times.
Yeah, exactly. You
They're
wrote
having
the article on
fun.
it.
It's quite the graphic. If you haven't seen it, the New York Times Magazine cover is worth Googling from a couple of months back. We happened to be at the Menopause Society meeting when that article came out. So we got a lot of questions and a lot of answers to think about.
Yeah.
Um, so I kind of set this up a little bit that what is the hormone of desire in women? Like in men, it's testosterone, it's androgens, which they're pre-hormones and breakdown products from androgens, which are the category. Testosterone is sort of the key hormone. And it's carried around by some proteins. So we have total testosterone, and then we have what's free and able to interact with our body cells. And testosterone seems to act in a lot of places in the body, but we're only going to talk about its role right now in sexual drive. And it seems to be that that is the hormone that triggers those receptors in the brain that send neurotransmitter messages, things like balance of serotonin and dopamine, and turn on the parts of the brain, and there's specific brain centers we can talk about if you want to, that are responsible for this famous term, the pathways of desire. And our hormone, our testosterone, is produced in two places in our body, our adrenal gland and our ovary. And then part of it is released as is, and part of it has precursors and metabolic products that are transformed into active something called DHT, dihydrotestosterone. We make the same amount from our adrenal gland. It's about half throughout our lifespan. So unless you have everything taken out, we all have some testosterone. That's why we still have muscles and hair and some other things like the things that testosterone does in other parts of our body. But the decrement that seems to be related to sex drive is the part that gets made by the ovary, which is about half, and it has different pathways in our body too. We make the most between 18 and 24. And then it unfortunately goes down from there. And by the time we're 40, we're down to that half. And then it kind of levels off. It
Mhm.
actually drops before most women hit menopause in the very early premenopausal years. And it goes down a little more in that 48 to 52 range. And then it actually picks up a little bit. And it has to do with metabolism. So some women are sensitive to that drop. And it's just that difference that seems to be the problem in the brain. And so the evidence supporting that is that when you give a little back, women notice a change or an improvement in their sexual drive. So we can give that. The problem is in the United States, we don't have an FDA-approved product, and that's a complicated story. But it's based on good research that it's safe and effective when done properly. And there are a number of places in the world that have government-approved standardized products for women. And we feel that that's based on the same research that we use it in the United States. We have to do other things to give it to people in the United States.
Yeah.
And we think about late reproductive age women because of what I just told you, peri and postmenopausal women, and there's ways to do it safely, and there are risks and benefits. I think that's kind of the top line about it.
And it can be challenging because
Yeah.
there, like again, you have to give. Generally, what I do is give the male formulation of it, but you have to get women to take 1/10 of the male formulation. That doesn't exist. So we have workarounds to do it, but it can be challenging to get it done. And if a woman takes it, there can be side effects of taking too much, right? I mean, if I'm right, you can get hair gain where you don't want it, hair loss where you do want it. You can get some permanent voice changes. Um, Acne, right? And so we want to make sure that if are taking it, they don't take too much.
Right. So in Australia, Great Britain, South Africa, and New Zealand, there's a product that's government approved. And the basis of that dosing is kind of like what I said earlier, we use here. It's called andropheme, if anyone wants to look it up. And I'm not advertising it, but it will give you an idea of like what is, if you want to read about it, what a standardized product is like. In the United States, most of the guidelines suggest taking a male product, like like a testosterone packet, 1% gel, and cutting it. Some people are now saying some of the research and values looking at lab exposure are that we should probably start closer to 1/15th or 1/20th and then go up. And the maximum would be 1/10th. And that's based on the circulating amount that we have when we're younger. So the idea is that when you're like about, if you want to be about the same as when you were younger, those the earlier years, you are about 1/10 of the male, right? And so that's how they come up with the dose. Now, it's kind of a challenge to get 1/10 of that packet out and get exact on the woman. So we say make it last. I'm saying 10 to 15 days or even 15 plus days at the beginning.
Right. I say at least 10 is what I say.
Yeah, but I used to say 10. I'm moving back a little because we don't
Yeah.
want to, data suggests that we want to start slower, so we don't want to retreat. Now, the reason you want to go too high is, first of all, basic, practical common sense. Like, why would you want to be in a male level when you never were in the first place? And if your point of comparison is like, I want it back, right? We're not trying to make you something you weren't. It's your point of reference is yourself when it comes to sexuality. And that's what I remind women. Yes, you saw some idea about someone that like, could do 50 things and have sex 100 times a day or whatever, but what was your best that you're looking at, hey, wait a minute, something's wrong with me. So if your level was in the physiologic range for younger women, why would we ever want to treat beyond that? That isn't what you were intended to have. And while it might make you feel super powerful or super this or that, we don't know that that's ever safe for you, right? So it's based on the safety. And generally, if I keep women and I follow blood levels more at the beginning when I do this because we want to make sure that we know what the dosing and the variability. But the side effects, even with that, you can get a little acne, sometimes a little hair growth on the face. I see that the data is like about 15 to 20% max. I don't see it very often, even in women who get some improvement. And I shoot for that like younger level blood level, younger age blood level.
Mhm.
You don't see a lot, but you sometimes see a little, and people put a put a little acne medicine on or use laser. It's rare. Where we get into trouble is you can get androgenic side effects, meaning too much androgen. And that's where like the male pattern hair loss, the deepening of the voice, more acne. And we don't know if there's some body changes that are associated with having too high a testosterone or a high blood count, which sometimes comes with too much testosterone. It's called polycythemia.
Mhm.
That's the biggest thing I worry about. And I've seen it in a few women.
Yeah.
And that may affect how theoretically your vascular system, et cetera,
Yeah.
right? And,
Uh,
and we worried about the liver when we used to use oral formulations, but not so much with the type we use now. We only use gels or transdermal. We don't generally, I know we agree on this, I think, is no pellets, right? We're not fans
No
of
pellets.
because you can't control the number.
And it
You
goes
can
way up
control the
high and
exposure.
then way down, right?
Right. So we don't recommend that. We don't have strong evidence and guidelines that support the use of pellets in women these days for
Right.
testosterone.
And a lot of women do tell me when they feel better with the testosterone, they feel more energy and they want it for muscle tone. And that's not why we're giving it. We're giving it strictly for libido, that if you feel those other things, when you use it, that's a bonus, but that wouldn't be a reason to give it.
So there's sort of a lot of dialogue, and this comes in some of the recent articles that we've been kind of mentioning. Does it help your cognition, your thinking, your mood, your muscle mass, your risk of fragility, fractures, or what's called sarcopenia or muscle or bone loss? And there's some emerging data, honestly, that shows some positive effects. But the question is, can you safely dose it to get those benefits and avoid the adverse side effects? And the research is not there yet, and the world experts are not recommending that for those reasons. If you happen to feel more enthusiastic, who knows why, right?
Right.
Like about things in general or more positive. Hey, that's great as long as we're in a safe zone,
Right.
right?
So it can be carefully used. And then the reason when someone said, why isn't it given more? Well, it's not FDA approved, and many people aren't comfortable giving it. But as the New York Times and
Yeah.
other press is coming out, more and more people are asking and more more of us are giving it. So carefully it can be given and it can be, I've seen it be very effective for some women. There are two other I want to make sure we're going to run out of time soon, but I want to there are two other medications that are FDA approved in this country. Do you want to speak to them quickly?
Sure. So remember, with testosterone, it's transdermal on the skin,
Yeah.
usually given in a gel, and it's off-label, but based on evidence. So we call it off-label evidence based. So that's like what you're looking for when you look for treatment if you're interested.
Thank you.
There are two other medicines that are FDA approved for desire in the United States. One is called Addyi, ADDYI, and it was originally approved for premenopausal women, but in very recent time, within the past month, I think, or month-ish, it was government approved for postmenopausal women. And it didn't have to do with anything other than just the process of the company getting FDA approval. And also wasn't tested in that many older women. So currently in the United States, it's for women under 65 because of like drug interactions or other things that weren't tested in older women. Maybe we'll get more research later. And this acts on those same things I was talking about, those receptors, the neurotransmitters, and the pathways of desire in the brain. It was tested as an antidepressant and found that in fact women didn't like notice that big a change in their mood, but their libido improved. So the component of the response that was most notable. And it doesn't make you a crazy nymphomaniac. It makes you just back to where you want to be. That's what women say, and it works moderately well. It's 100 milligrams once a day at night. There was initially some concern about low blood pressure, and which can be accentuated by alcohol. So we have some specific guidance. You take it when you go to bed. They don't recommend drinking more than a standard drink or 2 hours before, and better not to make it close to, more than that, no good, because it can lower your blood pressure. And it has standard side effects. A small percentage of women get headache, fatigue, but it's generally very well tolerated because it's taken at night before you go to sleep. And you give it an 8 to 12-week trial and see if it works. The other drug that's available and FDA approved in this country is called Vyleesi. It's a drug it's kind of like people are more used to this when it first came out. It's given on demand and it's an auto injection. Now in the Ozempic era, people aren't so worried about it.
Right.
And you poke yourself with a tiny little thin needle for a few seconds, and it raises the melanocortin pathway, which changes the dopamine balance in your brain. Same idea. And gives you intra-event turn on. And it lasts for about 12 to 24 hours. With the first dose, some percentage of women report nausea, but that is better with second and subsequent doses. So I tell people, since it lasts so long, use it, go to sleep, so you're not so nauseous, and then the next doses are not, and then have sex in the morning. And it does have a feed-forward effect, even though you don't take it every day, because people notice they have more turned-on experiences. And it works more on that immediate transition of feeling like, okay, I'm going to do this, and feeling turned on and saying, okay, yeah, I want to do this. And then it does improve other domains of sexual function. People notice improved arousal and orgasm too.
What are the contraindications to that one?
So the main contraindication for that is hypertension, because it can raise your blood pressure a little, but for women with normal blood pressure, it's not really clinically significant. So we usually check blood pressures first. It's not postmenopausal approved. So if you're okay, and it's only because we don't have research on those women, and we don't have trials in that age group. We did actually always have trials for postmenopausal women for Addyi. It was just an approval process. It's been available in Canada for women under 60 since the last few years that this drug has been available.
And my guess is insurance doesn't cover any of these, right?
Some insurance companies cover it if it's properly. It depends on your kind of pharmacy benefits you have. And both companies, if you go to their website, they have coupons and they have their own specific pharmacy that you can prescribe to, that they pair with, that offers some ceiling of costs and discounts. So there's variable coverage for them.
That's good to know.
Yeah.
Okay, so I have a couple of questions that have come up that maybe to wrap up, but how much is the right amount of sex a woman should be having?
Well, I think that there are we've been alluding to this, right? There are no standards, right? But what we look at are like, what do you have in mind for you at this time? If you were 21 and you were interested in sex every day or several times a day with somebody that really turned you on, But in this time with your partner, you'd be satisfied once a month, twice a month, 3 times a week. First of all, getting in touch with that. And the caveat to that is that because you don't have desire and you're like, that's all I could put up with to agree to, versus that's what I would be, it would appeal to me. Then the other question is, we didn't mention this, and because I was thinking only about the person, which is there a discrepancy or discrepant desire? Thank you for reminding me about that type of desire. Is there a discrepancy with a partner? So a partner might have one idea and you have another. And so even if that's not, the problem's not with the person, there might be a relationship issue where there's discrepancy that's causing conflict. And so you don't medicalize that and treat it if the woman's not distressed, but you address it as a partner issue. So that might mean couples counseling, or it might mean,
Communication, right?
right, it might be
Communication, I say.
communication, right. So
Yes.
one of the things that I teach when I talk to general internists and other primary care physicians is that one of the most important, the four things like that are on my list, if you want to learn four things. One is coaching for better communication. Number one, I'm glad you mentioned this, is coaching for better communication between partners.
Mhm.
And some of the things we could spend a whole time on that. How do you coach for better communication between partners? I do sometimes say, bring your partner in and let's talk together.
Mhm.
In the age of telemedicine, it's even easier because the person might not be dragged in, but they might be willing to sit in front of a camera.
Sure.
Say, come on. The other thing is learning about like lubricants and moisturizers and vibrators. That's kind of a category. Lubricants, moisturizers, vibrators is three, and vaginal hormones are four. And mention, I didn't mention testosterone, desire drugs, and a little and CBT because I think those are good things to know. But if you know those four things and you know that those other things exist and know how to refer to someone who knows how to do those things, you know a lot,
Mhm.
right? So those are ways that patients or people who are listening can interact with their physician and their clinician.
Yeah, that's always a point I make too. I probably would have been one of my points that we as clinicians should be bringing these things up to discuss, but it's also okay for you to bring up all of these things with your
Yeah.
clinician. For
So we
sure.
we have lots of little research papers and things that talk about how often
Right.
physicians ask. It's gotten better, but these days time is short and there's a lot
Sure.
of priorities. So learning to bring it up. I mean, we try to teach clinicians, doctors, nurse practitioners, physician assistants who are interacting with the patients to screen or to ask screen questions to find out from menopausal women what's going on, but they don't always have time. So you can bring it up and say, hey, I'd like to talk about this. And I think generally we find receptivity. But if they can't help you, ask to reschedule for a follow-up. So you're
That's right.
there for your annual. Say, you know what? If they seem like they're a little rushed, say, this is really important to me. Could I reschedule a problem-focused visit to talk to you about this?
And
Right?
it's okay for the provider to say that too. I really want to
Right.
do this with you, but we need to set up another time to
Teach,
talk for
teach
sure.
providers that, like, yes, this is
Mhm.
very important. Let's reschedule.
Yeah.
Not to try to cram it in because it takes a little time to walk through it. But you too can say, you can ask for that, like whoever's listening. You could say, could I schedule a separate visit? Or do you know someone who I might see to talk about this? And that's
Yeah.
where your center comes in and other things. And the other, right. And the other thing is there are other resources both in the community and the types of clinicians. There are pelvic floor physical therapists, there are sex therapists, there are couples therapists who can do sex therapy. There are very interesting things online that are responsible websites, like one we mentioned. If we have another second, I want to mention there is now a topical sildenafil available for people. I realize we didn't mention that.
Sure.
It's just becoming available. It's not available yet in New York, but it's like everyone thinks that these pills, the Addy is the pink pill, that it's Viagra. It's not like Viagra. It works on your brain, not your genitals. But there is now it's being prescribed through compounding pharmacies, but you can use topical Viagra or sildenafil, meaning on your skin to help with the genital arousal, and that's coming soon. So there are other treatments. The point is that and other treatments are going to be coming, and we just hope that we have the opportunity to let people know more about it. The things we can do.
That's amazing. So I was going to ask this question. I guess I will. Is it okay not to have sex as we age, or is it beneficial to remain sexually active as we enter later life?
So that's a complex question, right? What do you know? What do you think? I mean, I think I'll give you my answer. You can say what you think.
Yeah.
The, I mean, the first thing is that, like, we can't say this enough. One of the things that we need to do is give women permission not to have painful sex until the problem is solved. Because all it does is reinforce negative feelings about one's sexuality and one's partner and what sex is when we get older. You don't need to soldier on through painful sex. There's a way to navigate that, right? So, or if
You
you're
can get creative, right?
right. And then it doesn't always, the other thing is that sex doesn't have to be, like you said, creative. You're perfect lead in. Doesn't have to be standard intercourse,
Right, right.
right? And we mentioned this kind of at the beginning, sexuality can be a lot of things, right? And women discover that. That's one of the benefits of being a little more mature. And like it could look a lot of different ways, right?
That's right.
And I mentioned like terms like sex with yourself, solo sex. You don't have to have a partner.
That's right.
Um, and it is okay if it's not where your direction or interest is focused. So when it's to have no sex or not have a sexual, focus, it's a problem if it's distressing you. And it's also a problem, but not a sexual problem necessarily, if it's causing distress between you and a partner.
That's right.
The discrepancy needs to be addressed. So there's a way to approach a relationship issue, and what the resolution of that might be it varies a lot, you know. But if the reason that you're discrepant and avoidant is because you have a sexual problem that you want to fix, you want again, you want to be out of pain, then we have solutions. And that's where I focus my work, is only those things we start with that. Like, how do you see this? You know, it's two totally different people who come to me and say, I truly don't care. I don't have a sex drive, I don't care, but it's causing distress with me and my partner. Versus someone like, they're upset. I'm upset. Where'd my libido go? Where'd my orgasms go? How can you help me? Those are different questions, right?
And they both can be worked on.
Right, right. They're different, right?
Yeah. You are amazing. You have so much to share. We could speak for another 3 hours. Do you have a like sort of a parting message for us?
I guess all of it.
Right?
I think of the show, all of it. I
Yeah.
think that try to be empowered to raise the topic in a way that's comfortable for you. Don't be afraid to ask for help. Um, I think um getting clear on what you want versus what someone's asking of you as you approach this. Those are my parting messages.
Those are amazing messages. And to know that there are things that we can do for everyone, and it's, everybody can be treated differently. There's not one way to do this for
Well,
sure.
I'm so glad that you have this opportunity, this center, and that you have these dialogues. You
Yeah,
know,
and you are amazing, and you're an amazing resource we have here at Cornell. So
it's
thank you for joining us tonight, and
been
a
fun.
very enlightening conversation. And thanks everyone for joining us this evening.